Good afternoon and welcome to our medical lecture series. I am Dr. Khaled Hakim, Assistant Vice President of International Healthcare Partnerships and Insurance Development at Baptist Health International. It is my pleasure to welcome all of you to this informative presentation. I would like to extend warm greetings to our friends across Latin America, the Caribbean, and everyone joining us today. During this interactive presentation, you'll have the ability to ask questions via the Q&A feature located at the bottom of your screen. I would like to make a small parenthesis and remind those that by mistake have joined our panelist session to please refrain from asking questions or unmuting. Instead, please use the chat box or the Q&A feature located in the bottom of your screen. We appreciate your help and cooperation. I will be your moderators in today's lecture. This afternoon, I have the distinct pleasure of introducing Dr. Daniel Martinez. His presentation is titled Pillars of Men's Health. Dr. Daniel Martinez is a urologist at Baptist Health Miami Cancer Institute. He's a board certified in urology and fellowship trained in sexual medicine, andrology, and male infertility. His clinical and surgical focus includes treatment of male and female sexual dysfunction, incontinence, and other types of voiding dysfunctions. He offers the latest therapies for the treatment of hypogonadism and is trained in leading-edge treatment techniques for benign prostatic hypertrophy and vasectomy reversals, as well as sperm aspiration and retrieval. Dr. Martinez received his medical degree from Boston University School of Medicine in Massachusetts. He completed his urology residency at the University of South Florida, Masonic College of Medicine in Tampa, Florida, where he served as a chief resident. He then completed a clinical fellowship in sexual medicine, andrology, and male infertility at the University of South Florida Department of Urology, where he served as a clinical instructor. Dr. Martinez is a clinical instructor also at the Florida International University, Herbert Wertheim's College of Medicine. His work has been published widely in more than 25 peer-reviewed journals, and he has presented abstracts in over 50 regional, national, and international meetings on topics related to urology. He holds multiple patents in the urology subfields of sexual medicine, andrology, and male infertility. Dr. Martinez is an active member of the American Urology Association, the Sexual Medicine Society of North America, and the Florida Urological Society. Please let's give a warm welcome to Dr. Daniel Martinez. Dr. Martinez, what a pleasure having you. Thank you so much for accepting our invitation. The floor is yours.
Thank you so much, Dr. Hakim. It's always a pleasure to be here. So I'm going to share here my presentation. Perfect. All right. So first and foremost, thank you everybody for taking part in this very informative presentation. What I find to be, I call it the two E's, educational and entertaining at the same time. It's been many years actually since I gave a talk similar to this, and I think, well, number one, I was invited back to give it again, so hopefully it'll be as entertaining and as educational with a couple tweaks, of course. So as Dr. Hakim says, I'm Dr. Daniel Martinez. I'm a urologist at Baptist Hospital. I actually serve as chief of urology at Baptist Hospital, and I specialize in sexual medicine, andrology, and male fertility, which I have a clinic in the Miami Cancer Institute. For me, I think this is, I hold this subject very dear to my heart. I got into medicine through the field of sexual medicine, and I got into urology through the same field. I think sex sells, let's just say it that way, and it's an incredibly great way of opening up the communications, lines of communication with your patients, especially when it comes to overall men's health. And so that's why this conversation that we're having, or this presentation, is called The Pillars of Men's Health, because I think it starts off with something that's extremely important and dear to everybody's heart, which is sex. With that said, again, I'd like to thank Baptist International. I have an incredibly wonderful relationship with Baptist International. I think it's an incredible part of the Baptist family that does a great job. I enjoy everything I do with you guys. And I think what you guys provide and things such as this is wonderful. And I believe that we have quite an array of different aspects of medicine. We have medical students, we have physicians, we have some lay people as well that are tuning in to listen to this conversation and to see this presentation. So with that said, I have no disclosures. I don't get paid to do this. I love what I do. This is really truly for me an honor because it's my passion. But the one disclosure I do have is that this is a rated R presentation. You're having a guy who fixes broken penises all day give a talk. You better believe there's going to be a couple of slides that might make you feel a little bit uncomfortable, such as this. Actually, this is just a snake. Whoever was thinking something different, obviously, it's called the penis snake. It's from Brazil. Or this, which is just a carrot, right? Or this dog, which actually, believe it or not, sold for a lot of money. I wonder why. I think it had something to do with the actual fur and the coat that they had there. So I start off this conversation with something that's incredibly important, which is what exactly is a urologist? What is it that I do for a living? Because even within medicine, I went through medical school almost not having any idea what urology was. And it was really by pure luck that I got into this, because most people think of urology, these are the common misconceptions, that we only see men. Not true. That we're masters of torture. That one might be true. That we spend all days doing rectal exams. Maybe true as well. That we're not surgeons. We all have to go through surgical training, or that we're some sort of mythical creature like this, or I don't know what the hell this is. This is a Steven Seagal on a giraffe with a helicopter. But the reality is, this is what we do. As urologists, we're surgeons, and we deal with a huge array of different aspects of a man and woman's overall health. So kidney stones, leakage of urine issues, big prostate issues, cancers. I don't do a lot of cancer, but having the affiliation with the Miami Cancer Institute, we have wonderful urology oncologists who treat adrenal, kidney, ureteral, bladder, testicular, penile, prostate cancer. My field, which is more the male infertility, testosterone issues, sexual dysfunction, that's really what I deal with. And that's what the bulk of this is going to be about. So the important part, again, of what we offer, which is, men's health. And so we keep you cancer-free, feeling well, peeing well, and of course, having sex, which is what everybody cares about and everybody worries about. So there's been a lot of great movements as of late, the Movember with prostate cancer awareness, but I think it should go much further than that, which is beyond just prostate cancer. It's about, how do we look like this guy? That's actually, believe it or not, Sylvester Stallone at 70. Or how do we pee like this kid? Or what about this cat, It's about more than just prostate cancer, about men's health. And so that's why what I do for a living, which is, like I said, sex, infertility, and andrology is incredibly important. And a nice way to get guys to take care of themselves, treat their diabetes, treat their high blood pressure, go to the dentist, get your colonoscopy, because if you want to have good sex, you got to be healthy. And that's where this whole men's health movement comes into play. I always start with a little bit of prostate cancer, because I think it's incredibly important going over this. There's been a lot of controversy out there about prostate cancer and prostate cancer screening. And so this is a nice way to get into the more taboo portion, which is, let's talk about the prostate a little bit. It's the second most common cancer other than skin cancer, but it's most common cancer in men. 1 out of every 7 men will be diagnosed with cancer of the prostate. Second leading cause of death, first being lung, but it can be treated successfully. And so it's not just about diagnosis. It really is screening equals diagnosis equals survival. And how do we screen? Well, we're going to go over that now, but this is just some examples of a couple of people who have had prostate cancer and survivals. You got Robert De Niro, Colin Powell, that's James Bond, Carey, Giuliani, Warren Buffett. These are all prostate cancer survivors. So people that you would have never imagined had it, they survived it, and they're doing great. So when do you start screening? How often should you screen? Until what age? It really comes down to prostate cancer family history. So for those patients that have a strong family history, father, brother, uncle, that were earlier 50s, 60s, those are the ones that want to start screening at the age of 40. If not, you can start at 45. And it comes down to doing a rectal exam and a PSA. You got to have that romantic moment with your urologist. So I tell people, pick the skinniest fingers. That's what you want to do. And then from there, it's every year, every other year, depending on the level, depending on the conversation you have with your urologist. When do you have to stop having this romantic moment with your urologist? It all comes down to 10-year life expectancy. So if you're an 80-year-old guy, but you're in great shape and you're going to potentially live 110 years old, you probably want to keep checking. If you're 60, 70 years old, but you're in a wheelchair, you got some other terminal diseases, it may not be worth checking it, because for what? It's unlikely that the prostate cancer is going to do much. So the average life expectancy in the USA is 76. The recommendation is at least until 75, you want to keep checking. After 75, it's a conversation you want to have with your urologist. But if you look like this guy, the Dos Equis guy, everybody remembers those commercials. This guy's going to be 120 years old. So it really comes down to each person, but it is something that needs to be discussed, and it's something that cannot be ignored because of the importance and how common this cancer is. Okay, so this is sort of my take-home message from prostate cancer. So let's shift from the boring stuff to the entertaining stuff. So this is the god of Priapus. And it's incredible because we as a society are obsessed with penises. Phallic structures are all over the place, and we find it funny and entertaining. And it's all fun and games until something goes wrong. And when that something goes wrong, that's really where the patient tends to want to now seek help. And it's incredible how many of these patients have not seen a primary care, but they come straight to me. And I tell them, what do you mean you've never seen a primary care? Well, yeah, I don't have any other problems other than the fact that I can't get or maintain a good erection. So, well, there's probably some other underlying medical issues here that need to be addressed. So a little bit of history. I'm a big history buff. So the earliest references on records of erectile dysfunction come all the way from the 8th century BC. Samhita Shashrata discussed it. And it's incredible because up until recently, really, this was psychogenic, religious, supernatural ideologies. It wasn't until really the late 1900s that we started treating this as an organic disease. This is from a textbook from 1950s, where they said 90% of all cases of ED are relative or completely related to psychogenic issues. And really, it wasn't, can you imagine having this guy treating your penises? There's no way. It wasn't until the 1970s that these two gentlemen really created this paradigm shift, because these are the guys that created the first penile implant. So penile prostheses, this is Dr. Carrion on top and Brand on the bottom. They created the first organic treatment for this. And now we realize, okay, you know what? There's probably some other underlying issues, not just in your head. It's not just a curse that somebody put on you. And then in the 1980s, we started using intracavernosal injections. These are vasoactive substances get injected to the side of the penis. In the 1990s, that was it. The blockbuster drugs came out, the Viagras, the Levitras, the Cialis. And the rest now, you're seeing some other newer things come out. I don't have a lot of slides on it because the American Urologic Association really doesn't endorse it yet, but we got platelet-rich plasma, stem cells, lithotripsy, which, again, not recommended as routine, as part of standard of care, but you can tell that the boundaries are being pushed more and more and more. And it all started in the 1970s. But as Forrest Gump said, life is like a box of chocolates. You never know what you're going to get. ED is like a box of chocolates. You never know what you're going to get. There's a lot of different reasons why somebody would have these issues. And it's usually not just one of these. It's usually a combination of everything, okay? You have the psychogenic, of course, absolutely. I have a slide about this because I think it's important to discuss what truly is performance anxiety. Vasculogenic, so issues with the arteries, the veins, neurologic, endocrine, drug side effects. But some of these drugs you need to take, because what the drugs are treating can also cause ED, and even worse, can cause death. Surgeries that we do for cancers, radiation, diabetes is a big one. I always say that the number one assassin of a man's penis is diabetes. And of course, the aging process. Every man is going to develop some form of erectile dysfunction as they get older. But as I tell all my patients, don't worry, we'll make sure you're able to have sex until the day you die. So just to give you an idea, the big three: vasculogenic, diabetes, and medications. Again, it's usually not just one of these, it's a combination of everything. But the psychogenic part is a real thing. And I see in a day in my office, if I'm seeing 30, 40 patients, I'm going to see at least 3 or 4 young, healthy gentlemen, men with performance anxiety, or predominantly psychogenic erectile dysfunction. Now, what happens when somebody gets nervous and anxious? Something organic is actually happening. Your body's producing epinephrine and cortisol. These are our fight or flight hormones, right? This is if somebody puts a gun to your head, this is what helps you survive that. And epinephrine and cortisol are great for survival, really bad for sex. We actually inject epinephrine in men's penises if they show up to the emergency room with an erection lasting more than 4 hours. So imagine that same response is happening in your body when you get nervous and anxious. So we treat it like an organic cause. These patients do very well with medications. With that said, you have to take into consideration that there may be some other things going on here. And again, as they get older, it's going to get worse. But staying on top of these and making them understand this is a real thing and it's happening is really huge. And it helps them get through this and cope through this. Then they'll get to a point where they're going to have their confidence back. It may require less therapy, but it's a real thing. Neurologic issues, we know you got to have the nerves to fire appropriately, and that could be anywhere from the brain all the way to the peripheral nerves and the spinal cord. You got, of course, hormonal issues. Everybody that I see needs to get evaluated for hormonal issues, because you can have issues with your testosterone, with your prolactin, with your thyroid hormone either being too high or too little. Hyperprolactinemia is a real thing. And most guys aren't showing up like this guy in the middle. They're showing up with a blood test that may be slightly elevated with no other symptoms, or maybe this weird blurry vision. We know that the pituitary gland can develop these microadenomas, and one of the symptoms could be erectile dysfunction, so something needs to be evaluated. Arteriogenic ED, the same stuff that gives heart attacks, the same plaque buildup that you can have in your heart is going to build up in the arteries of the penis. The penile arteries, the cavernosal arteries, are a fraction of the size of the coronary arteries. And so you're going to see ED, it's a precursor to a major cardiac event. So if somebody shows up to me, they come in to see me and they've never seen a cardiologist or primary care, and they're that age or some other medical issues they may have, I tell them you need to see your cardiologist because you're not that far away from having a major cardiac event. Because the same stuff that builds up in your arteries in the heart is building up in your penis. So I know it looks a lot like I just ruined Taco Bell for everybody here. I'm sorry. Venous leak. So this gentleman right here is called Francois Gigot de la Peyronie. So he's the man who Peyronie's disease was named after. Peyronie's disease is a curvature of the penis, which can be congenital, but usually it's related to some sort of trauma or some sort of traumatic event. And ultimately what happens is your penis doesn't stretch out completely. The corpora cavernosum, or this is the surrounding structure of the corpora, which fills up with blood, has a scar. And that prevents the full extension of the corpora, which can ultimately cause some issues where the penis, the sinusoids don't trap the blood well. And so you'll have some of that blood leak out, and that may cause venous leak erectile dysfunction. So this is just an example of what a Peyronie's disease looks like. Whoa, sorry, double penis there. So again, it's usually not just one thing. It's usually a combination of a lot of different things that we're seeing, and realize that it's beyond just simply, you can't really simplify this for these patients. You have to discuss with patients and tell them, look, yes, we understand that your metoprolol may be causing it, but guess what? It's probably also related to some of the other things. You probably also, because you have your diabetes, although it's well controlled, that can do it, your high blood pressure, and now you got your anxiety that you have because you've had these issues. You had radiation for prostate cancer. So all these things that are coming together. So once we see these patients, it really comes down to how do we first evaluate them appropriately? And it's pretty basic in the sense that this is a clinical diagnosis. And so usually with a history and physical is what we need. And by physical, I mean, you got to take a peek under the hood. There's no way that you can have a patient who you're treating for erectile dysfunction and not have any idea what their genitals look like. So you want to do a full physical and history. And we do have some standardized questionnaires and specialized tests that we use. But the mainstay is really this good history and doing a good physical exam on these patients. Next, we do some labs, of course. I check labs. I check a full hormonal profile, total free testosterone, FSH, LH, prolactin. I check their thyroid hormone. I check their hemoglobin. Again, you need to take a peek under the hood with these guys. You want to know if it looks like this. You want to ask about some of the other issues or social issues that they may be dealing with and other habitual things. Are they smoking? Have they had trauma? What medications are they taking? Are they using drugs? There's a lot of different things that can worsen and or cause erectile dysfunction that are given by us doctors. But realize that although we know, for example, I always use metoprolol as one of those, blood pressure medications can cause ED, but high blood pressure can also cause ED. And even worse, the high blood pressure can cause heart attack or stroke. You're not going to have sex if you're dead. So yes, we know it is an issue, but we have to deal with that, and we will manage the side effects as necessary with these appropriate medications. Standardized questionnaires, I use them again because I am a sexual medicine specialist. There's really two major ones. You have the IIEF, or the International Index of Erectile Function, and the Sexual Health Inventory of Men. It's a great way to try to figure out who may have this, and another great way of trying to figure out how well am I doing treating these patients. So the IEF, it's a little bit, it's intense. It's a 15-question one. It goes over not just the ED, but orgasmic dysfunction, sexual desire. It's more for an academic setting, so it's great for the studies that we do. And you can see here it's quite involved. But the shim is great. 5 questions. You can incorporate this into any practice, and it's nice because it's a nice way of screening for this. So certain patients may be coming in to see physicians for something different, and a nice way of monitoring, having an objective number of how well am I doing managing these patients. So specialized tests, this is really stuff that not even general urologists do, mostly specialists like myself do this. We have a number of different things. This is what the injection therapy looks like, and we'll go over this a little bit more with the actual medication section and treatment section, but you can have a patient inject at home and or in the office and see if they react appropriately to it. With these medications are vasoactive, so you don't necessarily need stimulation, but the stimulation will help with obtaining that erection. This is an ultrasound. I do a lot of these. You can see a picture on the top that looks like the owl eyes. That's an actual cross section of what the penis cross section looks like. You have the two corpora on top, which fills up with blood, and the urethra on the bottom. The two on top, the little white lines are actually the corporal arteries. You can see how thin that is. This is a schematic of a cartoon of what it looks like. And we look at the flow. We look to see how well is the blood flowing in and is the blood leaking out. And so it's more, again, a matter of not so much diagnosing erectile dysfunction because it's a clinical diagnosis, but we have a better idea of how aggressive we can be when it comes to treatment when we have those. This is more historical. We used to inject the corpora with contrast, and we would see, does something leak out? They used to use this also for penile fracture. Yes, you can fracture your penis, believe it or not. And so we used to find areas where the corpora was cracked and it would leak out. You can see what a venous leaks looks like on the bottom there. But again, not using it as much anymore. And a lot of these, it's not as much diagnostic because it's, as I said before, a clinical diagnosis, but things that we can use to, especially if we want to be a little more aggressive with patients. This is also a machine we used to use historically. This is the Rigiscan. So at night, you put one of those rings around the penis and you sleep. And as you're sleeping, you're supposed to have these nocturnal erections, and this measures it. You can see what a normal scan looks like on the bottom left, and somebody who's not having nocturnal erections in the bottom right. And so somebody who's having erections at night, that tends to tell us it's probably more psychogenic in origin, which the other one is probably more organic in origin. This is also not so much actually historical because we will use this. We do a microarterial bypass surgery. The same way you do a bypass of the heart, we can actually do a bypass for a specific subset of patients that have a lesion, an area where the blood, for whatever reason, doesn't flow through because of an injury, usually a straddle injury. If somebody falls between their legs like that, we cannot stent the arteries of the penis because they're too thin. The rate of restenosis is astronomical. It's just through the roof. Everybody restenosis. But a specific subset of patients, you can do this bypass surgery, and we will figure out if it's a specific one area lesion by shooting contrast in some of the arteries of the penis. And so that's really where this arteriography is used. So again, in summary, like Forrest Gump said, it's like a box of chocolates, you never know what you're going to get. There's a lot of different reasons why, and it's important to know the reasons because then we can look into history and physical, and then based off of that, and depending on what we see there in some of the blood work, then we can get into the actual treatments. So the treatment really is what people really want to talk about, is how do we fix it? Okay, we know there's a problem, but what can we do? And I told my patients, like I said, I'll make sure you have sex until the day you die. It won't be with that penis you have when you're 18 years old, but we'll make sure you're able to get an erection that's rigid and sustainable enough for the entirety of sexual intercourse every time you want it. That's the goal, okay? And there's really 4 treatment groups, all right? We got pills, we got intraurethral therapies, you have injections, and then you have the implant. Now, within there, we use vacuum devices and there's sex therapy, but historically, we didn't have these. It really is until we told you in the late 1900s that we started seeing this. And historically, we're talking about, that's actually what a tiger penis looks like, believe it or not. I never seen one until I Googled that, so I had to include that in there. But they were using tiger penis and pig penis before. And then, of course, now we have a laundry list and things that we can offer. And this is all recommended by the American Urologic Association, okay? Remember I told you that we're not offering, we shouldn't be offering lithotripsy, platelet-rich plasma, or stem cells. But you can see here, this is really what is involved in the armamentarium of things that we can give patients. This slide covers pills and injections, really. This is a very famous slide from New England Journal of Medicine by Dr. Tom Liu, one of the origins and the godfathers of the field of sexual medicine. This is the actual smooth muscle cell that's in the penis. And you can see here where the phosphodiesterase inhibitors, the Viagra, Levitra, Cialis, Taxol, and Stendra works, right there, where the cyclic GMP is at. And where the intracavernosal injections, which is a combination of papaverine, phentolamine, and prostaglandin. And you can see here they work through a different pathway, which is why you can combine these. The injection therapy and the gel therapy is, again, a combination of prostaglandin, a very strong vasoactive substance, papaverine, and phentolamine, which is actually where the papaverine would be as well. So pills, Viagra, Levitra, Cialis, Taxol, and Stendra, that's what exists nowadays. Major differences is how long they last in your body, side effect profile, and how well you respond to one versus the other. This is my first step when it comes to treating patients. If it doesn't work, we can try intraurethral therapy, which I've done more gels than Muse. This is a suppository that's put into the urethra. It's absorbed in the urethra, so it's stronger than the pills. And then, of course, you have injections, which have been around since the 1980s, and these substances are put right into the actual corpora, very strong vasoactive substances that you have to be careful with, because that famous erection lasting more than 4 hours can happen with this. Rarely does it happen with pills or gels. This is my slide of the new sexy treatments that are out there. Again, the AUA does not recommend it unless you're in an actual randomized controls trial. So LIESWT, or low intensity extracorporeal shockwave lithotripsy, you're sending sound waves to the penis to try to, what they're trying to do there is regenerate some of the cells that may have been injured, help it to actually stimulate some growth and healing process. Same thing with PRP, which is platelet-rich plasma. You inject this stuff in there, and then stem cells, it's the same concept. You're injecting these things to try to heal whatever may be damaged or injured. Seems promising, but again, these are all very preliminary trials. They have actually come out instead of the platelet-rich plasma and stem cells. Probably not a good idea, because you can actually cause injury. I believe that the shockwave lithotripsy really will be more for rehab purposes, which we use already something similar to it, not so much sound waves, but we do use vacuum devices to try to rehabilitate and regain what people have lost, especially after prostatectomies or radiation. You can combine these therapies. The only thing you cannot combine is double high pills. So you shouldn't do 100 milligram Viagra or sildenafil with 100 milligram tadalafil Cialis. That can be very dangerous. And of course, we're going to go a little bit more into it, but you want to make sure that there's not a hormonal issue like a testosterone problem. Vacuum devices. This is my shout out to vacuum devices. I use them in my patient population. I think it's great to try to rehabilitate, help you regain length, girth, and function. We're not talking about using your Dyson at home, guys. We're talking about this. It's a pump that creates a negative vacuum pressure inside, which will fill the penis up with blood. I use it more again for rehab, but some guys will use it to have sex. You can use the actual ring to place it at the base of the penis. So it's pretty simple, straightforward. It creates this artificial erection, and then you place the ring, which will hold it in place. Not very expensive. They're effective. No systemic side effects. But again, yes, there's certain there's some downsides. You can't leave it on for more than half an hour. It's non-discreet. We won't be able to ejaculate. And if you leave it on for too long, you can cause some pain or petechia, which is a little like bruises. Surgery, wonderful treatment. Actually, the highest satisfaction rate comes from penile prostheses. But again, pills, gels, injections, implant, I think that's the end treatment, because it is irreversible. So you want to get to a point where you realize there's no other option. Vascular surgery, I don't really touch upon it, like I said, because it's pretty subspecialized. For the penile prostheses, there's two major implants. You have the malleables, which are these rods that you place in the corpora, and they're always hard. The difference is it's malleable, so you can pull it up and it stays up, and then you can push it down and it stays down. And then the inflatable, which is a 3-piece, we'll go over that a little bit more. Again, it's been in the market for a very long time. It does carry the highest satisfaction rate for patient and partner, which, let's face it, that's what happy partner is, a happy life. The inflatable, you're going to get flaccidity and rigidity, very similar to a natural erection, easy to use, dependable. It is surgery, though. It does carry certain risks, such as infection, and it is non-reversible. And of course, mechanical failure. But it's a wonderful treatment for the appropriate patient. And like I said, my happiest patients are my implant patients, partly because they've suffered for so long and they finally have something that, wow, I'm the way I was when I was 18 years old. And so in the right patient, it's a wonderful treatment. Those are the rods compared to the implant. You can see the differences. This is just a cartoon. You have the rods are just in the corpora that go up and down based off of you actually grabbing it and pulling it up and down. The 3-piece, or the inflatable, you can see there's a pump in the scrotum. The cylinder's in the penis in a reservoir. Whenever you pump it, you got fluid that goes from the reservoir into the actual penis. You get hard, you have your sex. Once you're done, there's a deflate valve, which you press, and it pushes all the fluid back. And you can see here in this cartoon, this is what somebody would look like actually pumping it. You don't really see anything from the outside. I get all the time people ask me, what happens if you squeeze the wrong thing in your scrotum? Well, you'll probably made that mistake once in your life, and you'll never make that again. This is how we place them: penoscrotally, infrapubically, or subcoronally, so you can actually place them through different routes. There's 2 companies. So you have Boston Scientific, which used to be the old AMS, who has, again, the 3-piece and the rigid and the semi-rigid. They also have a 2-piece, which is not as popular, but we use it in certain patient populations. They're great. They're very similar in the sense that they all have a pump, they all have a reservoir, they all have cylinders. They look a little different in the way that the pump looks and works, and the reservoir, how it looks and works. This one has antibiotics already coated on it, so it decreases that risk of infection. The Coloplast is the other company. You can see how theirs looks. You can see the malleable on one side. You can see the inflatable on the other. This one I tend to use more because the BioFlex, which is made out of, it's real tough. It gives you a girthier implant. I don't know if anybody doesn't want a girthier penis. And so it's nicer in that sense. The pump's a little tougher to actually use, but it also has its hydrophilic coating, which is great because you can take any antibiotic you want or antifungal and put it on there. It'll stick to it. So again, all these things were done in more recent times to try to prevent one of the risk factors, which is infection. Again, here's a hydrophilic coating. Hormonal therapy, we're not talking about looking like this guy. You know, we don't want to look like Dr. Hakim. I know that's actually a picture of him, right? That's back when he was a bodybuilder, I know. Testosterone. We live in a society that is obsessed with testosterone, and we want to put the blame on everything that's wrong with us on testosterone, but it is a real issue that we see. And even though women can go through menopause and everybody concentrates on menopause, andropause or menopause is a real thing. And so you have to keep an eye on this because these patients are miserable. Plus, not to mention that having low testosterone is putting you at risk for heart attack and stroke and all the things that people worry about if they have to get on testosterone. You're actually at a higher risk being hypogonad. So you want to look for these specific signs and symptoms. Some people talk about screening past a certain age. I don't tend to, but again, that's my practice. A lot of patients come to me, but it's reasonable to screen and to also even incorporate a questionnaire into your, if for those doctors out there, into your practice, especially the primary care physicians. And this is a nice way of trying to get somebody, they may be showing up for something else, but hey, guess what? This may throw up a flag. And you may actually be treating some of the other medical issues they have if they have low T by treating their low T. A lot of different ways of replacing oral agents, intramuscular injections, pellets, patches, gels, buccal. It works. And for those patients who have low T, putting them on a replacement therapy, which you have to understand, it's a lifetime therapy, man, it does wonders for their quality of life. Sex therapy, I think there is a big role. Unfortunately, it's not, I don't think it's utilized as often as it should be. It's great because it's nice as an adjunct, and it's really nice to try to get somebody to have better sex without actually having to give them some sort of pharmacologic therapy. It's wonderful to help decrease anxiety, develop sexual skills, communication, and negative thoughts. You know, you got to have both patient and partner there to make it work. That's one of the downsides, but it is non-invasive. It's curative. There's a lot of applicability. It's tough to find a good sex therapist out there. Miami has quite a few, which is great. I'm lucky in that sense, but it can also be time-consuming and costly. So, but it is something, again, that I utilize all the time. Again, not as a solo therapy, but as an adjunct therapy, meaning for really. All right, so let's shift gears real quick. This is the last part. Hopefully I'm not going too over here, but again, I'm very passionate about this. So I want to try to cover a little bit of everything. So everybody out there in the World Wide Web is seeing this. So we're going to shift from this guy to these guys. Believe it or not, this is a real mascot. It's a Brazilian mascot. I think the name is Nutsy or something like that, and it's meant to bring out the awareness of testicular cancer. So there's no way I would ever let any of my children buy this thing, but I found it funny when I saw it. So male fertility, really, it's any health issue that lowers the chances of getting a female pregnant. 13 out of 100 couples can't get pregnant with unprotected intercourse, and a third of the time it's related to male factors. Okay. 1 out of 6 couples are infertile. A couple of fun facts. So the average male ejaculate has about 100 million sperm. That's a lot. It really only takes one to get somebody pregnant. Over 300,000 babies are born a day. Sperm production, your body makes it, males' bodies make it every 3 months. So every 10 to 12 weeks, it'll make some sperm, and then it breaks it down, and then it makes some sperm and breaks it down. And then they last about 5 days inside a woman's body. That's why we tell people, if you're trying to get pregnant, you want to have intercourse around the time of ovulation, starting 2 days before every other day, because having a sperm there, it'll last there for about 5 days. And as that egg is coming in, boom, hopefully you have that match made. It's the smallest cell in the human body. To put into perspective, 5 micrometer, the egg is about 120 micrometers. So females' eggs are much bigger. And so, you know, it's spermatogenesis is probably the most sensitive process that we as men do in our body. And we know that it's incredibly important to maintain. Again, it's a great window into an overall man's overall health. If they're having issues with fertility, there's probably some underlying health issues that we're not picking up. So what organs are we talking about? You got your testicles that make the sperm, then it gets housed in the epididymis. Then when you want to ejaculate, it goes through the vas deferens, which is what we cut when we do a vasectomy, right? And that fluid will mix with the prostate gland and the seminal vesicle fluid. About 80+% of that ejaculate, when a man ejaculates, comes from that. A very small amount comes from the testicles. And then when you have an orgasm, which is a violent contraction of the muscles in your pelvis, that shoots out the urethra, and that is how you ejaculate. Okay. This is a electron micrograph of what it looks like. It's pretty cool. See how all these sperm around. The moment one sperm gets in there, that's it. The egg sort of shuts down. It closes the gates. Doesn't let anything else in there. So the testicles have two jobs. All right, making sperm and making testosterone. That's it. And we talked about already testosterone, the importance of that. Hold on, Dr. Hakeem really wanted to take a picture of that pig. I saw him there. I know. Can you imagine having that guy? Those are some impressive testicles. I know. So again, we talked about some of these, the importance of testosterone, what it does in a man. And for those medical students out there, you know, this is one of those algorithms that we learn, and it gets engraved in our brains when we're in medical school. But these are really the andrologic hormones on the bottom of what we're talking about. And when you have low T, you're going to have a lot of these these symptoms. You're going to have issues getting lean muscle mass, not thinking right, cloudiness, fatigue, low libido, your muscles are going to hurt. All these things can be related to low testosterone. But remember, that's the easiest part. So making the testosterone, you're going to have a guy with normal testosterone and still have issues making sperm, because that's a really sensitive process that your body has to be able to perform in order to be able to make this very tiny thing that ultimately determines our fertility. So there's a couple of graphs of what it looks like. You see the sperm, it's got the acrosome, which is what that's what activates when it gets into the actual egg. The head, the body, the tail. You can see inside the testicles, it's made in the seminiferous tubules, which is where we see spermatogenesis, all these things of meiosis that we learned about when we were in high school, really, genetics class and things like that. And we can see this is what it looks like in the microscope. You can see it all starts off as spermatogonia, then primary spermatocytes, secondary spermatocytes, spermatids, and then boom, it gets released inside the actual seminiferous tubules. They swim out to to join in all their brothers and sisters in the epididymis, and they wait for their time when they get called out of the bullpen. So when is it that somebody has the diagnosis of infertility? If they're having timed intercourse and after a year of unprotected intercourse, they're unable to get pregnant. If there's some other risk factors such as cryptorchidism, which is where the testicles don't come down into the actual scrotum, or let's say the female is older, not as old as this lady, but you know, advanced maternal age or some other factor, you don't want to wait a year, because there's a clock here, especially on the female side. And so you really want to start that screening process earlier in those patients. And the screening process is a history and physical. It didn't include physical, but that's important. Remember, checking under the hood, and 2 semen analysis. If there's any abnormality there, or there's still, you know, there's still some issues despite the woman getting evaluated, that's when you do a full evaluation. And again, history, the full thing. You got to tell people, you can't be shy with a urologist. You got to be very honest and open with them. You want to look at what supplements they've been on, a history of STDs, history of steroid use. Have you ever gotten somebody pregnant? Do you smoke? Are you a big hot tub person? Do you have a family history of cystic fibrosis? You'll see there's a genetic link there in a second. Have you had mumps? Do you take Rogaine? Again, anabolic steroids, I see it all the time. And then checking under the hood, you want to make sure that you know what their genitals look like. Do they have a varicocele? Do they have a vas deferens? Some people are born without it. What's their prostate feel like? It's important to know there's a patient, you know, if the patient look like this guy, all you have to do is look at them in the face and you're going to know what their testicles look like. But if you're not looking under the hood, you're not going to know that you got a squirrel like this. Varicoceles, very interesting. I feel like varicoceles carry a bad reputation. I see patients all the time who have gotten varicocelectomies, and I think maybe really they weren't candidates for it. Yes, we know there's a specific subset. This is when you have a dilation of the veins in the testicles, which can mess with spermatogenesis. But you have to have a specific subset of patients. Most patients that have varicoceles, which is very common, don't have any issues getting pregnant or getting somebody pregnant. In those patients that do have an issue and they have specific findings on their semen analysis, low concentration, low motility, low morphology, those are the patients that may benefit from a varicocelectomy. So it's important to know, but realize that a lot of patients will come to me with a lot of concentrating on the varicocele and how this is the devil living in my scrotum. No, it's not. You've had this since you went through puberty. But keep in mind that this is a potentially surgically treatable issue that may improve the chances of getting a pregnancy. And it's all a numbers game. I tell people, I'm going to try to make you as fertile as I can possibly make you. Semen analysis times 2, again, it's changed. The World Health Organization is the one that determines the parameters, and you can see the 2010, which is really what we're using nowadays. We look at count, how much sperm you have there per milliliter. Are they moving right? Are they moving forward? What do they look like? The endocrine evaluation, the same stuff that I would check if they come for erectile dysfunction. I look at FSH and LH, which is the pituitary gland talking to your testicles. I check for prolactin as well, because we know that the prolactin issues can also cause issues with fertility, not just erectile dysfunction. Testosterone, this is an older range. 250 to 850 really is the new range, but these are just some examples of what normal levels look like within these actual lab tests that we order. And ultrasound, I get ultrasounds in almost everybody, because you'll be surprised what you'll find. Well, they're really indicated in patients who physical exam-wise, it's very difficult to do it, whether because they're heavier set or they've had different surgeries or their scrotums are real thick, or if you're worried about a cancer. I have picked up testicular cancers as a cause for infertility. So that's why I use it so much. This is what a normal healthy testicles look like. There's some other things that we would order, and that would be if patients have really abnormal findings in some of these initial screening tests, like very low sperm count or no sperm count, whichever, azospermia, very low volume ejaculate, or they have some other significant issues with their hormonal profile. Retrograde ejaculation, we see it in patients because of side effects of medications, or maybe prior surgical issues or spinal cord injuries, which essentially the ejaculate doesn't come out forward, it goes backwards. And there's ways of getting sperm from these patients. We can have them ejaculate, and then we have them urinate, and we spin that down, and guess what? We're going to find sperm there. And so there is a lot that can be done with that. Same thing with some patients who may have a blockage. Remember, I told you, all these things, the sperm, the prostate fluid, the seminal vesicle fluids, they come together and they come out of the ejaculatory duct, which goes in the urethra. Well, sometimes that can be obstructed, or we can find certain things in that area, the prostate area, that may cause some issues. And so some of these patients, doing an ultrasound, you may find some abnormality there. That's what the ejaculatory duct looks like. And you'll have some of these the vas deferens dilated because of the blockage. Genetic screening. So this is very important in somebody who has no sperm, because we will find genetic issues here. So no sperm or very low sperm, we check for something called a cystic fibrosis transmembrane receptor. We check a sex chromosomal full karyotype, because occasionally we'll pick up somebody who's 46XXY, or instead of being 46XY, they have the XXY, which is Klinefelter's. And then, of course, Y chromosome microdeletions. I'm going to talk about that because that's a very important one. So again, cystic fibrosis is a genetic link there. If you have a family history of it, this may be something that some people are born with. These also tend to not have a vas deferens on one of the sides. And we check for it. That's something that if we find, that explains what's going on. Again, the sex chromosome abnormalities, this is what a normal chromosomal karyotype looks like. This is what Klinefelter's looks like. So notice there's 2 X chromosomes there. And we'll pick this up. Somebody be walking around not knowing that they have this, totally healthy. They're completely infertile. We check this, and this is what's going on. On the Y chromosome of a man, there's a specific area that codes for spermatogenesis, making sperm. If you're missing that, that's called a microdeletion, and that can cause infertility. There's 3 types, A, B, and C. It's important to know, because if you have A and B, I can counsel that patient and say, forget it, you're not going to make sperm. C, you could, but it's something important that we want to check. There's some other specialized tests, morphology would be one of those I see all the time, but it really, there's no major studies to show that it does anything. And then they'll check the integrity of the DNA, but there's no major studies to show that these really do anything. But these are things that will be ordered by myself and or the reproductive endocrinologist, which are the people that do in vitro, as a means of trying to figure out what else can we do, what else can we use to explain what's going on, and or what can we do and use as a number to try to improve. Treatment. Clomid, it's a great medication. I use it for my fertility patients, but I also use it for my low testosterone patients. This is a female fertility drug. Everybody tells me, you're not going to give me that. No way. I tell them, you're not going to start walking. You're not going to grow, put a wig on and walk with high heels. Just because it's a female fertility drug, men and women are wired the same way. So the difference is the stimulation to the end organ. You got your ovaries, it does one thing. You got the testicles, it does another thing. And so what this will do, it blocks the negative effect of the estrogen in your body, which goes up to the pituitary gland and shuts it down. You see here, I spent all day drawing this stick figure with testicles. On the top, you got your pituitary gland, which produces those two hormones, LH and FSH. The LH and the FSH will trigger the testicles, which is the little thing on the bottom, to do two things. FSH makes your testicles, the Sertoli cells, produce sperm. LH will make the Leydig cells produce testosterone. Testosterone gets converted to estrogen in everybody. Estrogen goes back up and shuts this down. And so what does Clomid do? Clomid prevents that negative shutdown. So you're going to make more LH, more FSH, which will trigger your testicles to make more and better sperm. It will also, like I said, we use it for younger guys who have issues with testosterone because it works great. If you have a blockage, you can try to treat that. Like I said, this is what the ejaculatory duct in the verum montanum, you see in that's a cystoscopic picture of where the ejaculate comes out of. If that's blocked, we can resect it, and now all of a sudden you have actually the ejaculate coming out. IVF, it's a great tool that we use. My part, of course, is trying to get the male patient as fertile as possible. But in men who can't get the sperm out, or when the ejaculate sperm's not in there, we can actually go in there and look for it. And so we can try to get sperm to use for in vitro. And we can retrieve it from the epididymis or the testicle. We can do it percutaneously, which is with a needle or open, and then they can freeze it, or they can thaw it, or they can use it. So there's three major ways of doing it. You have the testicular sperm aspiration, which is, again, a needle that you aspirate out. You have testicular sperm extraction, where you're making a cut and then you're removing it. And then the microscopic version, which is where we use high-powered loops or a microscope to do that, which carries a higher success rate to try to find it. This is what it actually looks like in real time, where we actually will take seminiferous tubules many times in the setting of a reproductive endocrinologist's office, where we're handing off the specimen to the embryologist, and they're looking for stuff in real time. Really fascinating things, and works very well. The most common form of infertility is a vasectomy, let's face it. And so in the appropriate patients who have had the vasectomy in 10 years or less with a healthy female, we can reconnect the pipes. And so we do this. It's a microscopic surgery, and it works very well. There's actually a picture of one of the ones that I've done. And what we'll do is reconnect the good side to the good side, get rid of whatever scar, make sure there's a good lumen, and that will hopefully allow the sperm to flow through again. In vitro is another option. So for those patients that have issues with especially a female factor, in vitro is great, especially if it's advanced maternal age. It's a higher success rate than the vasectomy reversal. But again, it's a little more expensive. So there's a couple of other things that you have to take into consideration. You can see this is what actually removing it from the epididymis or the testicle, that's what it looks like. Same slide I just showed a little while ago. So I think that's it. So this is, again, my shout out to Men's Health. Remember, guys, urologist is a man's best friend. Take this as a nice introduction and or way of getting your patients to become healthy. You know, you can use that, the reason behind why they should control their diabetes and high blood pressure, and why they should take their statin for their cholesterol, is because, hey, you're going to have better sex. What better motivating factor is there than that? So again, this is actually my home office, but as I said, I practice also out of the Miami Cancer Institute. Thank you so much, everybody, for being a part of this, and thank you, Baptist International, for continuing to invite me back. You guys must forget every time that I give this a talk, the potential of how many penises might be popping up on the screen when I do it.
Dr. Martinez, there's no way to follow this up. I mean, this has been one of the most amusing and incredible scientific yet fun presentation ever. We truly, truly enjoy having you every time. I cannot stop laughing. I mean, yes, I can't believe you showed my picture with the 20 or 25 pack. I mean, yes, that was me at one point. Dr. Martinez, we get a lot of calls, especially from our international patients, wondering about this crazy thing that you did mention, which could be a myth or was a myth at one point, and potential advancements in the treatment of ED. And it had to do with what you mentioned. One, it was a PRP treatment, and the other one was obviously the shockwave therapy type treatments. And they are wondering, because obviously there was the small research that was blasted worldwide, and now everybody's up in arms wondering if this is something that is available to them. Can you quickly elaborate a little more as of why, what is it, and why is it not necessarily the treatment of choice, since we have such a great gamut of treatments, especially at your level in your office?
Yeah. So especially the way that I practice, as your urologist, especially if you're board certified, you should practice utilizing evidence-based medicine. And American Urological Association puts out best practice guidelines every year, which is what we're supposed to use. These are people who are much smarter than I am. So we're supposed to use that as our guide as to what we should be offering our patients. There are quite a few things, and I tell people, open up the Miami Herald sports section on a Sunday, you're going to find all these clinics that are going to offer you the world, and you have to be careful because some may not be harmful in the sense that you're going to hurt yourself, but it's going to hurt your wallet. And so a very common one, very popular one is the lithotripsy. Now they've done studies to show, and they're mixed. There's no major study to show that this is something that is going to work, or how it's going to work. It's not standardized. I would be making a lot more money than I make right now if I offer that in my office. But again, what I provide my patients are things that have evidence-based guidelines and evidence-based medicine. I think in the future, what ultimately this stuff is doing is it's utilizing sound waves to try to trigger your body to heal itself. And I think ultimately there will be a role for it potentially in more of the rehabilitation part of it. I talked about the vacuum erection device as a great tool for men to use it if they've had injuries such as prostatectomy, or they have Peyronie's disease. So I think at some point we may be using it for that. The magic pill or the magic bullet, as what people are unfortunately seeing and reading, it's not a magic pill, it's not a magic bullet. It's not going to fix this problem and give you that penis you had when you're 18 years old. And so the reason I don't provide it is because, again, I utilize these best practice guidelines and evidence-based medicine. With regards to out there, what you're going to see a lot of clinics that will offer it. And unfortunately, a lot of these places are taking advantage of patients who have an issue that's really very personal and very, it's a very sensitive thing. And so many men will do a lot of different things out of desperation to try to get there. Shockwave lithotripsy, you probably won't injure yourself so much. It'll injure and it'll hurt your pocketbook because you're going to pay thousands of dollars for something that really isn't covered and really probably won't work much. The other stuff, the platelet-rich plasma and the stem cells, the American Urological Association, they flat out said not only it does not work, but you can actually hurt yourself, so you should not be offering it.
Well, thank you for clarifying the air on this. Obviously, we have come a long way in the past 15 years, just to say the least, in regards to making this sensitive subject something that it's okay to talk about and go back to the physician and say, listen, I'm having this problem. I'm still young and I need to do something about it. So we're hoping, honestly, that with these type of talks, and obviously with the advent of new technology and being able to research, that we can actually have patients seek the help that they need at the right time. There is a question in the panel that says, good afternoon. If you have a prostate enlargement, does it eventually become cancerous?
That's a great question, and it doesn't. There's two parts. So I tell all my patients, for those are my patients that are out there maybe listening, they know it. I say two things happen to men as we get older. It's a joke, but it's the truth. Your penis gets smaller and your prostate gets bigger. So we have voiding issues and we have sex issues. None of that has anything to do with cancer, but there is a third thing that we could potentially develop, which is cancer. So an enlarging prostate is a purely benign, yet very quality of life affecting issue. Cancer, prostate cancer, usually is asymptomatic. And so that's why it's so important. That's why I always start off, especially with this talk, discussing prostate cancer, because I think if you don't get screened, you're not going to find it, because most patients that have it will not have symptoms until it's way too late. And so you may have symptoms of an enlarged prostate, but that does not mean that you have cancer or that you will even develop cancer. So it's a good question.
Yeah, certainly is. And obviously you did touch initially about the type of lifestyle that we should, all men should really carry. And one of the things that come to mind is obviously the risk factors that some men would potentially have in their lives that will translate into ED eventually. One that comes to mind is obviously obesity. We know that in men, if I didn't read wrongly, it was 40% in all men, and then it increases as age increases up to 60, it probably is 45, if not about that number in percentage. So definitely there should be some kind of a preventive measure for us to live a long, happy life. And with your interventions and with your different types of treatments that you potentially can put a patient on, definitely we could see a flip and a change. Your final words in regards to what we should do as men in order for us to live that happy life eventually. What comes to mind?
Yeah, I think, as I said, this talk is great because as I alluded to, it's educational and entertaining. Well, the same way, there are two H's. I talked about two E's, which is the education and entertaining part, but there's two H's to life, which is health and happiness, right? And so living that happy life, the only way you can do that is being healthy and doing things in moderation, making sure that you go see your primary care physician, making sure that you don't ignore your overall health, but quite the opposite. You want to be proactive because that's the way to live a healthy life. And you may use sex as a motivation. That's what I do for a living. I treat that and I manage it. So I see that. And as I said before, what better motivator to use than sex to be able to control your diabetes and your high blood pressure and all these other things. So in order to live a happy life, you have to live a healthy life.
We agree with you, Dr. Martinez. This is so much fun. We can keep you for hours just to listen and to see those graphics. I can't stop laughing. Some of them are definitely, and I did capture some pictures, trust me. So thank you so very much. We're going to let you go. We know how busy your practice is, and we want to thank you on behalf of our entire international team for accepting our invitation and for sharing this incredibly informative presentation. And to all of you for participating today, thank you so much for joining us. If you do have additional questions about today's presentation, and some of you medical students, if you do feel that you need to ask something about urology or the specialty of urology, please let us know. For all our patients that are listening and Dr. Martinez's patients that are listening, if you do have additional concerns or more questions, please feel free to write at BHIWebinars@baptisthealth.net. That is BHIWebinars@baptisthealth.net. We will promise to make sure to send them to Dr. Martinez for him to respond and send back to you. And we look forward to seeing you all in our next medical lecture series, which is scheduled, I believe, for May 24th, 2023. Thank you once again. Thank you so much, Dr. Martinez. Have a great afternoon.
You too. Take care, everybody.